Welcome to VerifiedRx, your prescription for success. Brought to you by the Vizient Center for Pharmacy Practice Excellence.
Joint Commission recently introduced an updated accreditation manual to streamline and simplify processes, provide better support, and more efficiently share best practices. Vizient partnered with Joint Commission for a member-exclusive webinar breaking down the new manual and spotlighting key challenges healthcare organizations are navigating during surveys. Joining us today are two experts leading that conversation, Dr. Robert Campbell, Senior Director, Standards Interpretation, Accreditation Decision Management, Medication Safety Division of Accreditation and Certification Operations for Joint Commission, and Diana Scott, Principal for Regulatory and Accreditation Services here at Vizient. We'll cover top takeaways, clarify key updates, and share insights to help your organization stay ahead. I'm Carolyn Liptak, Pharmacy Executive Director in the Center for Pharmacy Practice Excellence at Vizient, and your program host. Diana, Robert, welcome to the podcast.
Thanks, Carolyn. We're really looking forward to it today.
Thank you.
To get us started, why don't you tell us a little bit about your backgrounds? Diana, let's start with you.
I lead the regulatory and accreditation team here at Vizient. I'm a nurse by background, and I've been with Vizient for over 26 years.
Thanks, Diana. Robert, how about you?
I am the Senior Director for Standards Interpretation, Accreditation, Decision Management, and Medication Safety here at the Joint Commission. I've been with the Joint Commission for 13 years. The first part of my career at Joint Commission, I was a surveyor, and then prior to that, I was a Director of Pharmacy and Quality at a community hospital here in Florida, and it's a pleasure to be here.
Thanks, Robert. It's a pleasure to have you. There's been some changes made to the hospital and critical access hospital manuals. Can you tell us a little bit more about that?
The goal was to detangle those CMS regulatory requirements from the Joint Commission requirements. We decided to pull those requirements that the Joint Commission have that are above and beyond those of CMS and place those in a National Performance Goal chapter. The other thing that we wanted to do was delete or remove duplicative requirements within the manual. And in doing that, we were able to reduce 46% of the elements of performance in the critical access hospitals and 48% of the elements of performance in the hospital program. The ultimate goal was to provide clear, concise language along with the origin and intent that we believe will lead to operational efficiencies as organizations continue their journey through the accreditation process.
Okay, so these changes are to the manual, but are there any changes to the chapters themselves?
Yes, we got rid of the wave testing chapter and put some of those components in our National Performance Goal chapter. We eliminated the National Patient Safety Goals and converted them to National Performance Goals. We also took the Life Safety Code and Environment of Care chapters and transitioned that into a Physical Environment chapter.
Tell us some more about the National Performance Goals and elaborate on those that are relevant to medication safety and pharmacy services.
So that's where the remaining of our requirements went that weren't crosswalked to the COP requirements. There are two exceptions, nursing staffing, suicide risk reduction, that are crosswalked and part of national performance goals. But overall, those national performance goals are the non-crosswalk requirements. Those that relate mainly to medication safety and pharmacy services are Performance Goal 1, where we have patient identification and management of clinical alarms. Performance Goal 6, which is about safe opioid prescribing. And then the bulk of the medication safety stuff is at Performance Goal 14, which includes things like review of pharmacy orders when the pharmacy is not open 24/7, ADC override reviews, selection and procurement of medications, labeling medications in procedural areas, anticoagulation therapy, medication reconciliation, and antibiotic stewardship.
Thanks, Robert. Diana, you work very closely with Robert on the top medication management challenges. Which ones were shared on the Accreditation 360 Medication Management Update webinar yesterday? And do they appear to align with what you're seeing?
Absolutely. We see this as in direct alignment to what we've been hearing from the organizations directly. Medication administration per order, the clean medication area, and space surrounding that, techniques. Then the medication order clarification, there's been some issues around that. And I know your area of expertise, Carolyn, is around compounding. And that's been some areas that we've seen or heard from the organizations about stored medications and how they're labeled. And then removing any of those expired or damaged medications. They're just prevalent all over the organization. It's so hard to keep up with that. Following the package inserts in regards to medications being stored, and then having a complete medication order and the policy that coincides with that.
Yeah, thanks, Diana. We sometimes hear the same challenges repeatedly. Diana, you mentioned med administration per order. What are you consistently seeing related to pain management not being aligned and titration orders?
So with the pain management orders, there's frequently issues related to therapeutic duplication, where it appears that there's not a clarification as to when to give which medication first or for what. Also, you can't see if there was an intended multimodal therapy. Frequently, we see that in postpartum. A lot of times medications are intended to be given together, but you don't see what the communication is between pharmacy and the provider and the nursing staff. So it's difficult to ascertain whether that was intentional or it is in fact therapeutic duplication. In regards to the titration orders, the orders that we've made that leap to better titration orders. However, the piece related to documenting the indications or having a correlating evidence of why you are doing the titration seems to be the area that's still a pretty big challenge.
That makes sense. Robert, what are you seeing with insufficient communication between pharmacists, prescribers, and nurses when it comes to medication orders?
The biggest thing is making sure that when the pharmacist does clarify the order, if any changes have to be made, that those changes are made in the order, or that it was clear in the documentation as well within the pharmacy system that the intervention was approached and clarified with the ordering provider.
All right. Robert, what are the themes around labeling requirements for stored medications?
The top themes that we saw there were lack of revised expiration dates on medications and IV fluids, failure to label opened or prepared medications properly, and then we continue to find noncompliance with the manufacturer or organization storage guidelines, specifically for those medications that require refrigeration.
There seems to be a challenge with putting new dates on the IVs that have had their protective wrap removed, particularly in the procedural department where they go through them so quickly. A lot of times they're not expecting them to remain. They expect to be using them. And so then when they do have instances where they're not used, there's no dates on those. So those tend to be problematic. In regards to multi-dose vials, sometimes those are not stored appropriately, meaning that they could be in a location where you should have them in a safe place where you're not having them contaminated by patients, and those are being reused. Sometimes we see that.
Removing expired meds from patient care areas and in the pharmacy seems like a constant challenge. Robert, are you seeing anything different in this area than previous years?
Not really, Carolyn. It continues to be insulin vials that are expired. You load insulin into your automated drug cabinet for a particular patient. The patient leaves. No other patients on the floor are diabetic. The insulin ends up expiring, but it's still available in the patient care area. Outside of that, we are seeing sometimes in compounding, you can use those large volume bags for given times based on the chapter, but there's no labeling on them, and they're not removed from the compounding area when that time frame has expired.
Diana, you and Robert talked about issues related to storing meds, specifically per the package insert. Do you have any examples of those?
One of the examples that is most frequent is in regards to succinylcholine. They are frequently being stored in the anesthesia carts and they're no longer refrigerated, which is absolutely fine, but you do have to follow a new expiration date. And one of the challenges is different vendors have different requirements. So if along the way you've switched who you're receiving your succinylcholine for, you may have a different expiration date based on not being refrigerated any longer. So it becomes challenging for the organizations to keep up with that, to make sure that when they are removed and stored in the anesthesia carts, that they're using the correct unrefrigerated expiration date. Robert, do you have any other examples that you want to add to that?
The other component of this that becomes challenging is that if you are using a medication in the original manufacturer's container, succinylcholine is a great example, then you have to follow what the package insert has related to storage conditions. But when it comes to compounding products, you're only bound to the package insert stability and storage information if you are compounding or preparing that medication as outlined in the package insert, if it has that information. If it has the reconstitution components, it has the final container closure device, it has all those other components listed in the USP chapter, and you prepare the medications in that particular way and follow all of that information, then you are bound to the stability and storage information. Conversely to that, if the package insert doesn't have that information, or if you choose to use a different volume for reconstitution, a different product for reconstitution, then at that point you are able to use your own stability and storage data that you may have from some evidence-based literature or published literature. It comes down to how you prepare the items, if the original container or not from the manufacturer, and then how you prepare those that require preparation.
Yeah, that's super helpful. Now let's talk about sterile compounding. Some common issues seen inside the pharmacy regarding sterile compounding noncompliance include hand hygiene, garbing, PPE, and cleaning and disinfecting. Give us some examples of what you're actually seeing on surveys.
A lot of this has to do with not following the organization's policy and procedures. And what we find is that staff are not using nail picks to clean under the fingernails with running water. There's a failure to disinfect the gloves when they come outside of the ISO 5 environment and become contaminated. Not removing all the jewelry that should be removed, reusing chemo gowns when doing compounding hazardous medications. And then we are seeing some situations where a second pair of shoe covers are not put on when you're compounding and then not removed when you leave that compounding space to prevent the traces of the hazardous medications from getting spread throughout the facility.
Which is one of the goals of USP 800, is to prevent that exact thing that you just described. Also, the physical environment and facility cleanliness, along with cleaning and disinfection practices in those areas, have been noted as a top challenge. Can you give us more specifics in those areas as well?
The biggest thing that we're seeing is when you start having issues with chip paint, peeling paint, cracks on the walls, cracks in the floors, the ceiling tiles are not sealed correctly to the drop-ins, and damaged surfaces, it affects the ability to be able to adequately clean and disinfect that area. Those particular areas have a high level of scrutiny. When you start having those issues, then we do score that because it limits your ability to actually properly clean and disinfect those areas. The other thing that we've also seen in this space is missing documentation for the required daily or monthly cleaning. In addition to that, the techniques that were being used or the agents being used were inappropriate or unapproved. Therefore, it really wasn't providing that clean area that was needed. And then with the revision to 797, the majority of the country has adopted the revision at this point. We are finding lapses in people completing that monthly surface sampling that's required now with the USP 797 revision.
Another area of concern around sterile compounding is competencies. One of the newer USP 797 requirements includes competency assessment for immediate use compounding. And there's a lot of confusion on what immediate use compounding is. Can you explain for us how Joint Commission defines and evaluates immediate use compounding?
Joint Commission uses the exact same definition USP does. There's some misunderstanding of some of the interpretation and some of the FAQs published by USP, but we've worked closely with USP leadership and confirmed that our understanding is correct. We would define immediate use compounding in one of two situations. One would be where you are compounding a product. You're not utilizing any type of controlled area or space, so you're not using ISO 5 hood, you're not using a compounding suite. Examples of that would be things like preparing medications during resuscitation, preparing items in the ER, preparing items that are needed not necessarily for resuscitation, but immediately needed in the critical care space. The second area that is considered immediate use compounding is when medications are prepared from the manufacturer's container for use and not immediately used. So if you remove these items from the original containers and then you prepare them for use and they're not immediately used, that's also considered immediate use compounding from a sterility perspective. And so those are the two areas that we see that. And we see the second one more so in anesthesia, preparing medications for the next case, either while the room's being cleaned or as the patient's being taken out of the room or potentially going to get the patient and bring the patient into the room, the operative suites. Those are the two areas that we see the most immediate use compounding.
It's helpful to know that your definition is the same as USP's. What are the minimum required elements for immediate use compounding competency?
The minimal elements are that you have to make sure that you're covering concepts of aseptic technique and that it's competency based. There are very few concepts of aseptic techniques that would apply in this situation. So really it's making sure you adequately disinfect the top of the vial before you stick a needle in it, that you clean the ampule area with alcohol swab before you break the top of the ampule. You don't touch the needle. You don't touch the barrel of the syringe. That's the components that you need for aseptic technique. It can be that simple, 3 or 4 bullet points. The next thing is competency-based means you have a question, a test of knowledge. So it could be a 1-question test. Do you have to swab the top of vials with an alcohol swab? That could be the extent of what you need. It needs to be kept simple. It does not need to become complicated. What we will not be looking for, so I would encourage organizations not to go down this road. We are not looking for fingertip testing. We're not looking for media fill testing. We're not looking for a didactic test with all this information that's listed in the chapter. It really can be that simple and that quick and easy to get done.
Thanks for clarifying. What else are you seeing around compounding competencies besides immediate use?
We are seeing some timeliness now that you have to go to the every 6 months for a component of the competencies. We're seeing organizations have had struggles getting that kicked off and going. We did give some time of leniency at the beginning. We've kind of moved past that at this point, though. Organizations are still challenged with trying to get this done every 6 months. And it's seen both in small and large organizations. Small organizations because of resources, large organizations because of the number of people they have to get through it. Other things that we're seeing is there are new requirements now for what has to be in didactic training, and we're finding organizations are not inclusive of all of that information in their didactic training. And then lastly, making sure that those individuals that are cleaning the pharmacy compounding suite, especially if they're not the pharmacy staff, so if it's environmental services, making sure they have appropriate training that is reflective of what would be important for them to understand as they enter that space to do the cleaning.
Could you give us a little more detail around what you would expect to see for environmental services training?
The chapter leaves it up to the organization to determine, but there are key things that need to be considered that we think are important. For example, understanding how to perform hand hygiene, understanding how to don and doff their PPE, understanding what products are approved and not approved for use in the compounding suite. And then lastly, understanding the technique for cleaning, because a lot of these cleaning requirements are very specific, and making sure that those that are doing it understand the order in which they have to do it and the way in which they have to do the cleaning when they're in that area.
Diana, you expressed some concerns during the webinar around hazardous drugs. Can you talk about what you're seeing?
The issues that have been identified by our organization through their Joint Commission surveys have been around appropriate use of PPE, staff, and this is both pharmacy as well as nursing staff being familiar and aware of the organization's policy on handling and disposing of hazardous medications. Those are the primary areas that have been raised by the organization.
And Robert, what do organizations need to know around what Diana just brought up?
The first thing is that a lot of organizations have taken USP 800 at its whole and have not considered compendial applicability, meaning only certain components of 800 are actually enforceable. Certainly all of 800 is important, but it doesn't have to be followed exactly unless their particular state requires such. The first thing I would recommend is people should look at their policies. A large portion of our observations are based on organizations' policies that they've boxed themselves in with. Once they've made sure their policy is where they want it, they really need to go back and make sure that all of the staff understand what the policy requires. And importantly, they have purchased and have available all the equipment that's needed to support the policy. Having those things done. And then lastly, we have to make this stuff easy to operationalize for our bedside care providers. So if we're going to require certain things to be done, we need to find efficient ways to make it a part of the workflow for that floor staff so that we're not sending them to 5 different areas to get stuff just to conduct one task. That is an important component that we have to take into consideration when we think about noncompliances. Have we equipped the staff with easy workflow processes or at least consolidated workflow processes to still keep everyone safe, but do it effectively and efficiently?
Robert, you've given good rationale and examples of why it's important for there to be a clinical representation on the product review committee so that as products are changing, there is an opportunity to confirm that we have the correct supplies that go with those new products. Just food for thought for everyone to keep in mind.
Robert, is there anything else you'd like to add?
It's important that our accredited organizations understand we haven't taken anything away. We haven't added anything. We're still going to conduct the same survey activity that we always have. Individually at your organization, there may be something covered we haven't covered before. That's part of this, is to drive that consistency so we evaluate things the same as we move across organizations. The things that are different is going to be where stuff is scored. It's going to have different numbers, potentially different letters in some cases. But if you're compliant today, you'll be compliant tomorrow. Most importantly is in the new survey process guide, when it is the last 200 pages are tools that our surveyors use that we've made available now. A third of the survey process guide really is the test questions and the answers to the test. It's already right there for you. If you want to start using that in your survey this year, you're still going to be compliant. If you don't use that and use the current stuff, you're going to be compliant January the 1st and forward.
Great information to know. Thank you, Robert and Diana, for joining us today to share your thoughts and insights. It's been great chatting with you. Join us for more VerifiedRx podcasts. Subscribe today. Like us. Send us your comments. We'd love to hear from you. VerifiedRx is a prescription for success and is brought to you by the Vizient Center for Pharmacy Practice Excellence. Thanks for listening.